places. And so Giovanna and I have been talking about what she's going to present. And so I'm going to turn it over to her. Her title is Understanding Capacity, Lessons Learned in the Dual Role of Grantee and Grantor for a CDC COVID-19 Disparities Grant. And I must say that a bulk of my work, as I referenced when I was talking about my work in Wisconsin, has been in public health. And the line between public health and community psychology is quite fine. And so it's really wonderful to have a presentation from a Department of Public Health. So Giovanna, take it over.
All right. Well, good morning to everyone. Glad that you guys are here. Hope that you get a few takeaways from what I'm going to talk about today. And then more importantly, hopefully we can have some lively discussion towards the end, because this will be an overview of a project, but there is a lot of detail, obviously, not within the slides. And so that's where the discussions come in. So I will begin in talking about, well, of course, we all know COVID, this interesting time frame and epidemic that we've gone through as a public health entity. So I'm going to talk about how we had the opportunity for a COVID-19 Disparities Grant process, which was a unique process for our agency. Going to share some of the lessons learned from community engagement during that process. And then at the end, we may talk about some skills that are applicable to both or from the community psychologist perspective in public health. And that will be more discussion, not necessarily something highlighting. So as mentioned, I'm in Tarrant County, Texas. So Fort Worth is the largest city within Tarrant County, but just a little bit of demographics. So we have a population of over 2 million, average age 34, race, ethnicity, we're predominantly white community with Black and African American secondary, Hispanic third, and then we have a growing Asian population. Our main languages are English, Spanish, Vietnamese, and then we also have a growing Arabic population as well, which is interesting as we continue to look and do our community health assessments. So there we are in the big state of Texas. And then here is Tarrant County. And I know this is kind of a blurry little zip code map, but I use it to point out that when we looked at COVID and when we were looking at identifying where our disparities were taking place, primarily, we saw increased COVID incidents in about 16 of these zip codes. Most of those zip codes were our heavily concentrated minority population zip codes and or zip codes that had high social vulnerability indexes. So the Disparities Grant overall had its own strategy. So it was a CDC grant. We had to identify one or more strategies to engage in, and those strategies range from expanding existing prevention resources and services, increasing and improving data collection and reporting, building and leveraging infrastructure support, and mobilizing community partners and collaborators. And as an entity, we chose to engage in projects across all 4 strategies, with the ultimate outcomes that CDC would like to see were around ultimately reducing COVID-19 disparities, but improving testing, contact tracing, and improving state, local territories, community capacity and services to prevent and control infection. The gist of the grant was looking at those disparities that were not new during COVID, but they were exacerbated during COVID, and trying to identify what could be done so when the next pandemic or epidemic occurs, we will be better apt to care for our populations. So that's ultimately the work of the grant. So we, as a part of this grant, decided that we would serve as both a grantee. So we received the award from CDC. It was the largest award that this department, Tarrant County Public Health, has received in funding history. It was a $27 million award. But we also, and so internally, we said that we would serve as a grantee. We would host or implement about 11 internal projects. Those projects would focus on infrastructure support. We would look at developing some systems approaches across Tarrant County in identifying the need for a Tarrant County equity plan, and working with organizations who may not have, diversity, equity, and inclusion staff, but working with them to develop better policies, and pulling them together again to address equity across Tarrant County as a whole. We would also enhance some of our internal data systems, because during COVID, we recognized that having accessible data was difficult, both internally in how data was being collected, but then also across the system. And then just manpower is where that general infrastructure support came from, that we needed more people for phones. We needed more compliance folks, and we definitely needed more staffing in areas such as epidemiology and disease investigation. But we also decided that we would serve as a grantor. So we didn't want to keep all of those dollars internally. We wanted to get those dollars out in the community, because it would, one, help to build the capacity of our community partners. It would show collaboration from our perspective, and it would expand our reach for our programs, because Tarrant County, as I said, is a very large community, and we knew that we could not have the greatest reach if we just kept dollars internally. And so we issued a RFP, typical process. We estimated that contracting process timeframe would take approximately 3 months. We underestimated, because with the county court system and approval process, it took, in most instances, 6 months to get contracts and established and awardees up and running. We would award between $250,000 and $500,000 per project. We also wanted to make sure that we were trying to take an equitable approach to our subawards. And so we really wanted to focus on organizations, or approach organizations to apply for the RFP who were established and engaged in the community already. Also had a focus on diversity. We wanted to disperse it between different community organizations, healthcare organizations, academic institutions, et cetera. And we wanted to take a social determinants of health approach, because that is where we saw, again, nothing new, many of the disparities. So we ended up funding 11 subrecipients. Many of you are familiar with social determinants of health. And so we really sought in the RFP process, when we were looking at our awards, to try to award groups who were already doing work or had a history of doing work relative to the categories of the social determinants of health. And so I'll go through some of those. What I want you all to take from this is when we looked at our social determinants. So these were the projections, so some background information on the orgs we awarded, but then the estimated reach is their projection of how many folks they anticipated to reach. I failed to mention that the COVID-19 Disparities Grant is a 3-year grant. So we were awarded in 2019. We're approaching the end of the 3rd year. However, we have been granted no cost extension years. So work will continue until next year. So in the area of education, we funded the UTA at Arlington, University of Texas at Arlington. Approximate staff, 6,000 folks, said they could reach probably about 490,000 in the population, focusing on Hispanic and Vietnamese, their key strategies. They were going to utilize class standards, so to develop, culturally and linguistically appropriate communications, and improved health communication materials. Because one of the things that we learned within COVID is that how the information was relayed, again, this is nothing new, we needed to vary that communication across the population. Also in education, we funded our other academic partner, which is University of North Texas Health Science Center at Fort Worth. You all can see their staff, estimated reach 260,000. They were going to focus on mothers and families through home visiting, protocols for expectant moms, and then also direct service with vaccination for the pediatric and young adult population, utilizing their mobile unit. When we looked at the social determinant of economic stability, we ended up funding a local foundation, which is called the Chris Howe Foundation. Their work has been very community focused and providing trainings on economic development and economic tools. They are an organization that only has 2 dedicated staff, but their estimated reach, as they told us, was 360,000. They would conduct a number of town hall meetings, also create health education materials, collecting data through those town hall meetings to inform the development of a social media campaign. Then we looked at neighborhood and built environment. We have a partner called Healthy Tarrant County Collaboration, who truly knew the environment. They have conducted assessments around food deserts and food stability within the community. They are staffed with 1 person as their executive director, looking to reach 6,000 folks. But they were going to use a strategy which they were calling community corps influencers in the Stop 6 area. Stop 6 is an area within Fort Worth that has historically been underserved, underrepresented. And so they wanted to, and it had low COVID vaccination rates, but high incidence. And so their goal was to utilize and train folks who lived within that community to deliver community health education in their everyday settings, and those folks would receive a stipend. Social and community context, we have our Hispanic Wellness Coalition. We ended up funding staff of 1, target population, Hispanic and Vietnamese, and their area of expertise has been outreach and through utilization of health fairs and other strategies. Also under social and community context was the Fatherhood Coalition. Fatherhood Coalition is completely volunteer ran by a number of participants across the community. Their estimated reach was 500,000, and they also were seeking to establish health ambassadors to look to deliver community health education, focusing with the delivery from the male perspective. Then we have our healthcare partners. My Health, My Resources is our mental health agency here. They are staffed with over 1,400 folks. They were just going to reach out to internally with the development of COVID toolkits for youth and adults seeking services through them. And those toolkits contained testing supplies, educational materials, coloring books for the kiddos, a number of different thermometers, a number of different things, again, that we found throughout COVID that some folks couldn't even, test at home, or they didn't even own thermometers to be able to monitor their health status and determine when they should seek more emergent or urgent medical attention. Then we have JPS, or John Peter Smith Hospital, which is our county hospital. You can see their staffing and their estimated reach was 42,000. They were going to focus on health equity in their community outreach, targeting many of those zip codes that I mentioned earlier that had high COVID incidents, but then also looking at transportation, not just for COVID appointments, but transportation support for clinical services. Again, addressing disparities that existed pre-COVID, trying to make sure that folks could not only get to their COVID appointments if there were, or to the doctor around COVID, but some of their general health care needs. And then they would also do other outreach. So as we began this process, we talked about, or we looked at, across the spectrum, you all saw the different sizes of the organizations and what capacity building efforts could we provide in the initial stages of the project. And so we looked around programmatic efforts and helping the organizations establish performance measures and objectives, because we found, regardless of the size of the organization, many folks did not have a clear understanding of how to define those measures so that we can then evaluate them at the end of the project. We put in place monthly technical assistant calls for every subrecipient, and then also our internal project leads, so total of 22 projects going. We created a reporting mechanism, a centralized reporting mechanism, so that we could collect in a timely manner the information that we needed to then pass on to CDC for our quarterly reports. And then we provided training on grant management, because many of the organizations, although they may have received grant funding previously, they may not have received federal funding. And because we were also acting as a funder, we had our own internal guidance that we needed to share as well. And then on the financial side, definitely orienting them with audit requirements, and then reimbursement, because this was a reimbursement-based grant and funding opportunity. And so it was very important that the subawardees understood what was required for reimbursement, because without reimbursement, many didn't have the dollars to do the work. So what we learned over the course of this process, so as a grantor, any project is going to have technical challenges. We found that there was extreme difficulties with reimbursement and the reimbursement process, and that was across the board. And it was just a matter of differences in audit and finance guidance, how folks collected payroll, et cetera, and what would be acceptable. There were errors around in processing times, which was extremely important with some of our smaller organizations, just the ability to get us invoices so that we could get them the money that they needed to then do the work. We identified that many organizations overestimated their capacity, and that capacity was impacted either through staff turnover, limited training for staff, and limited understanding of evidence-based outreach strategies. We also saw some adaptive challenges within the subs. Speaking, more along the lines of outreach strategies, just limited understanding of the impact of reimbursement on those strategies, but also training and outreach training. And so although some of the orgs had relationships within the community, those relationships we found were somewhat limited. And many of our orgs had duplicated or were wanting to duplicate efforts. And so, for example, we have an African American Health Expo. Well, all of the organizations doing outreach wanted to be at that one event. And the purpose of the grant and funding so many folks was to spread out our resources across Tarrant County. So we saw duplication within the community. And so we had to talk and try to get them to understand how to, reach out in different areas, how to develop, different relationships. Now, mind you, we're trying to do this at the same time that we're trying to implement our own projects and keep, all of this work going. And then there were differences in philosophies and practices around, in the program management area and around grant management. And in that, we even had one of our 11 subs that ended up returning or ending their contract because they were not able, with the amount of documentation and requirements of those technical pieces for reimbursement, but then also just some differences in how they believe they should be doing their work, which was different than what they wrote in their application. So we had one that discontinued their contract. And then we had another organization who just never got a project off the ground, but that's, we'll talk about that a little bit later. So then we also, walked away recognizing, or we've, at this point, 3 years in, we along the way continue with quality improvement. So we've implemented or had to implement some stronger technical assistance. We had to create and provide templates for a number of things. We had to provide outreach training because we had community partners who wanted to, as an example, intended to reach out to the Hispanic population and hired, Spanish speaking staff, but it was Spanish speaking only staff. And so they had no way to communicate with those folks. And so we had to provide staff to go out and provide training also on just outreach, strategies, helping them to identify additional places to go. We provided lists of, from the technical aspect of what was an allowable cost for the grant. So what could be reimbursed so that we didn't continuously go through these processes of looking at invoices and having to reject them because there were things purchased that weren't, allowable. And then we had to supplement services such as translation. As you saw, many of the subs were reaching out to populations who spoke additional languages other than English, but they did not have the resources to translate the materials that they were creating. And so we used internal staff for that. And then as a grantee, so internally, we're not perfect. We learned some things as well about our processes, which were, including the fact that we needed to have our own templates of ways to disseminate information regarding our policies and expectations and funding guidance as soon as practicable. Because as we were going through this process, we also recognized that some of our auditors and finance folks had different understandings of what was allowable. They also had their own understandings of outreach and what it took or meant to conduct outreach. We would get questions such as, well, why would you need a coloring book? Why are we paying for coloring books? Well, it's to provide, education to the youth or to keep them engaged so that we can then, discuss, or the subs could discuss and have conversations with the adults. They didn't understand the concept of incentives when people were doing, health fairs, and there were things that we had to explain to them that these are just, additional tools used in that work. Making sure that communication was consistent within internal departments, we recognized was a challenge for us. Tarrant County, as a government entity, is very large. The public health department is 500 plus folks. And so there's a lot of different communication arms and areas. And then we need to make sure that we are disseminating information about our recipients and their activities to the public on an annual basis. As you're engaging in the process yourself, our communications partner, our communications team overlooked the fact that we wanted to make sure that we had a transparent process about what we were accomplishing, but then also what our partners were accomplishing. And then I didn't mention like accountability systems to just monitor adherence. So we had to beef all of those things up because, as I said, this was a very large award and a new process for the agency. But given all of that, we still had and are still seeing some programmatic successes that I wanted to share. So UTA created their first Spanish first Spanish language news story, which was on long COVID. Excuse that typo. And it was broadcast on Univision, had over 24,000 viewers. Chris Howe Foundation created some materials that were featured in the Texas Metro News. And they were, although a very small organization, one of our most productive organizations with their town halls and attendance and just their ability to get the community to engage around COVID. On the provider education front, the University of North Texas Health Science Center created a CME module for providers to provide training on how to communicate with vaccine hesitant patients. That was a challenge. And then internally, we invested in a SharePoint site, which is, or actually is QuickBase, to establish an area for historical data and peer sharing across the subawards. So we found that it was also important for them to be able to communicate and see what each other were doing. And so that site and the QuickBase app that was established helped allow for that. Then we had some successes just, within the community. I mentioned the Stop 6 Community Corp members, and they were doing more of a peer education model. They've made over 19,000 contacts. Again, this is just using community members to share information wherever they are. And those members will also have the opportunity to become certified community health workers through the development of Community Health Worker Institute that our agency is establishing. And that institute will be one of the only free CHW training institutes in Tarrant County. The others have minimal cost, but ours will be completely free. And we are starting with COVID education, and then we will expand and add different modules so that our community health workers, depending on their area of interest, our module build out will include chronic disease prevention, maternal child health focus, et cetera. And then internally, we've established our community health access program, which provides or assists community residents with providing healthcare benefits and enrollment in the healthcare marketplace. We became a Medicaid enrollee, so we can help them with their Medicaid, state Medicaid applications. We can also help them enroll in insurance plans offered through JPS, which again, I said was our county hospital, and they have their own insurance plan. We can connect folks to other financial assistance programs and food resources. And those will be programs that the Community Health Worker Institute and the Community Health Access Program will be sustainable programs that we are building into our infrastructure. So they will extend well beyond the grant. So in conclusion, basically the funding opportunity provided us a unique role to serve as both a grantee and a grantor. It allowed for greater community collaboration amongst a more diverse group of partners, many of which we would not have engaged in to the degree that we did with this grant, because we were able to both provide them with technical resources, but also with funding. And then it did expose the need for greater capacity building internally and externally. And so we have laid out a plan going forth to continue to work with, especially our nonprofits and our community-based organizations, to just do general capacity building around providing them trainings around diversity, equity, and inclusion, trainings around just financial management, project management, program planning, many of the things where we saw and or they indicated that they needed additional assistance. So. All right. And those are the technical pieces of the presentation. As we engaged in this work, so there's no slides. Let me end this slideshow so I can just chit chat. So when we looked at, as we engage in this work and we think about the careers in public health that that the skills of community psychologists will definitely lend themselves to. Within our agency, we have in the areas of community health equity and engagement. Sorry, I thought I saw a note. And we have our health equity staff, those folks, and then our community outreach. So those folks are always doing coalition building. They are always engaging in larger small group facilitation, working to develop, recommendations and policies. We also have a number of assessment focused areas. So our community health assessment coordinator and our community health improvement planning. Again, when we engage in that work, it is looking at the population level, it's taking into account not just direct services, but engaging the community to identify where the challenges and needs are. And so we have those types of positions. We also have our data or biostatistician folks who are there for us when the community requests access to data on a given disease or population level. Those folks are there to provide that feedback, and all of those positions were engaged in this project. So that's why I wanted to kind of highlight some of those. Questions, thoughts?
That was fascinating. And so I'm wondering the kinds of questions that came up for people. I have a half dozen came to me, but let's hear from other folks first.
Oh, thank you so much. This was amazing. So I was thinking when you were talking about, I guess my question would be, how did you guys come up with like all of those missing pieces, right? Because you talked about something I didn't even think about, I guess, took for granted. Folks didn't even have thermometers to make sure that they were able to assess what their health was on a regular basis. How did you guys develop such a comprehensive look at what folks' needs were?
Well, I wish I could say we were very proactive, but it wasn't. It was retroactive. It was as our disease investigators and as our community outreach specialists were engaging the community and talking to folks about, barriers and challenges that they faced in dealing with COVID. And we would be giving a recommendation such as check your temperature, and if it's above, XYZ, we had many community members say to us, we don't own a thermometer. And so then we had to come back and say, okay, we did a quick survey of the folks who had been calling into our call center. We shot out a survey to try to gauge how many people this impacted, and it was quite a few. And so based on that, we then said, okay, we need to provide. And so everyone who was tested through us, we would tested positive through us, we would mail or deliver thermometers to them. And then for other folks, they could put in just a request and we would have them and they could just come and pick them up. And so again, that infrastructure support was very important, because trying to deliver with the amount of cases that were coming through. And it wasn't always perfect, because sometimes by the time we were able to get a thermometer to a family, they were coming out of, their COVID symptoms and recovering, but at least they had it for future use.
Many times what looked like a deficiency in the part of the grantee was really a miss between the department and the community. And it's really important, and you do a nice job of that, of not saying, well, why don't they know how to track numbers? But as opposed to saying, maybe what we're asking for isn't exactly reasonable. And I think that's, we can, the departments I've seen can get caught in very rigid, we ask this of everybody, our hospitals comply, why can't you? Well, you're only a staff of one, too bad. You applied for money, you should be able to do this. And giving them the capacity to respond is so important. And it requires a good deal of respect of them and some humbleness on our part to sort of say, well, yeah, that was maybe not the exact right expectation from our position. Maybe we should have expected that they wouldn't have thermometers, So it's an interesting, tricky place. And I like the way you worded, what did the grantors learn and what did the grantees learn? Were there other things like that you found? Oh, Marek, are you asking? You have a question?
Well, yes, I have some kind of reflection. Well, it was totally overwhelming. The size of the project, the amount of work you put into it, the amount of people involved. I just can't even imagine what kind of effort it was on the side of people who are organizing this. It was a huge job. For me, I'm mostly interested in the content of what all these thousands of people did, with the audiences, especially this educational part of it. I hope you will have some kind of publication or materials where I could go to these details, because I'm not so much on organizational part of it, but I'm interested really in educational part of it. So what did they do? What did they teach? How did they do it? Yeah. So, and when it was the most effective and when it was not effective. These are the things I'm interested in.
Yes, and we are, so at this phase in the project, so we are looking at beginning our evaluation. We've been looking at, different quality improvement methods along the way, but looking at evaluating the outcomes of the work, and looking at helping the orgs to come up with strategies. As I mentioned earlier, we talked about the performance measures. And what did they see? And we have some, some of that roughly. So we know, the number of providers, et cetera. So we have some outputs, but really trying to look to see at the end of this, it'll be a 4-year period. What impact did we see in the areas that we focused on with regards to, either COVID incidents or testing? And then there are some of our partners, UTA, for example, is actually testing one of they're doing pre and post test on the materials that they developed, which were, if you recall, for geared towards the Hispanic population, and I believe Vietnamese population. So we will have some of that, and we're going to look to put that out first for our community to say, here's, what we got, here's the resources that we got, here's how we used it, and here's what we saw. And then from there, we'll see what else we can put out as far as publishing. And I was going to say, go ahead.
Go ahead.
No, I was just, Tom had mentioned earlier, like where else were there other places that we saw, kind of the, a disconnect or if I use that term, like a disconnect between, our expectations and or, the ability of the, partners. And, a lot of it, we learned lots. There's so many things that I couldn't even put in this presentation about what we've learned just about the various organizations themselves and their needs, but then, also how those needs reflect on what occurs within the community. And so we have these under-resourced, segments of the population. And when we look at these groups who, are some of our more prominent groups doing outreach, but recognizing that they're not touching, some of these areas, and some of them are major cities. And we heard from those cities. We heard folks who said, you all are only doing things in given areas. And so continuing to work with them, even beyond COVID, just to expand the reach, get them the tools and information that they need to expand their reach, but then also knowing that they always have an open door with us, so that if they're seeing something, they can communicate that with us and we can alter our practice. And an example of that is with COVID testing. We had the Hispanic Wellness Coalition come to us, and while we had mobile testing vans going out, we had boots on the ground, people doing door-to-door, et cetera. Most of our testing sites, like their hours of operation, especially our mobile sites, none were on Sundays, and very few were on Saturdays. And we had the Hispanic Coalition come out to us because they were doing work, they were doing work in the Asian community, or one of our Asian communities, and said, hey, they're not testing because they need testing on this particular day. And we would not have known that. And it was a subpopulation of our Asian community. And we would not have known that. And and it was actually a Sunday, they preferred the testing on a Sunday. And so we had to, adjust some things because nobody really wants to work on that day. But we readjusted, and we saw that they actually came out for the screening. So that was good.
First, I also just want to express my appreciation for sharing the information, and also just the work, because while you put it on slides and walk through it, I'm just remembering in 2019 there wasn't even a vaccine, so what local health departments were dealing with on top of trying to do a project at this scale. Just sending lots of appreciation and love your way, knowing what that was like, or from a step removed, just
Yes.
hearing what that was like from the local health people I was working with at the time. And we similarly, we had a just recovery for racial equity, not at that scale, but it was interesting to hear some of those same challenges, or how do we redo the reimbursement? The reimbursement process didn't work for organizations that had one person, or, so what did that look like to push back and try to change and still meet CDC requirements? So just a lot of it was hearing lots of overlap. I'm really interested in also the range, because you had health, from health systems to one person grantees that went from a huge range. And so I'm wondering what kind of learning took place across those organizations. So were the larger systems, because they were in the SharePoint group, were they open to learning from, your smaller organizations that were definitely reaching populations that maybe they weren't? Any reflections on that?
Yeah, so to some degree, so all part of our TA, so we had the monthly individual TA calls with the ORs, but then we had quarterly group calls with all of the sub-awardees. And the intent was for them to then learn and communicate what each was doing, and to minimize some of that duplication I mentioned. So we can't have all 11 sub-awardees at one event trying to solicit the same information or provide the same education. And so we did create those quarterly calls for that. And in some instances, I can't necessarily say across large to small, but some of our medium size, they did. One group shared or developed a material or a resource, and another group adopted that resource and disseminated it. And the QuickBase and SharePoint sites that we developed allowed them to load those materials there so that folks could borrow and utilize them. The coloring books were a hit because as folks, even though their target population might have been adults, recognizing that people show up as families. And so that was a hit. And so they utilized some of those materials as well. And so, yeah, there was some peer sharing and learning, I believe, that occurred. And there's probably some that we didn't know about. That's just what, they shared with us. So I like that question.
It's very hard to get systems to learn from each other. I spent my whole career trying to get human services to collaborate, and they have a million reasons why they shouldn't work with each other. A lot of it starts with, well, I've done this forever and I know how to do it. And they don't. And they don't admit what they don't know, and they don't listen to the community. So it's amazing. And so in this project, you had people who were really in the community. Then you had people that fit 1,400 staff. It's quite a jump.
Yes, quite a jump. And relationship, just the value of relationships and the sensitivity of relationships, we were keenly aware of that over the course of the project. Like I said, we had a grantee who, had to end their contract, and having those conversations. And so we saw from our perspective that even after we provided, additional resources and tools, they just could not do it. It would have been a miracle for them to be able to, not the work in the community, but the technical aspects of submitting the reimbursements and those things. They just did not have the capacity to do it. And even though they tried to bring on an umbrella organization to help, that organization wasn't, willing to front all of those dollars for them because they were a $500,000 grantee. And so having those conversations and being sensitive to their needs, but then also recognizing that there's a point where sometimes you gotta, throw in the towel. And how do you say that without damaging the relationship? And without them feeling like we pushed them to quit. And so it was a very complicated and complex, conversation. But ultimately we let them make the decision, and they made the decision. So.
Could you imagine that there was a way of doing that differently to save that relationship?
Well, hopefully we will still be able to work with them going forward. We serve them in a number of different ways on their boards, and we provide materials for them. But in this particular grant, aside from us doing the work for them, which would not have been an equitable solution because we weren't able to do it for the others, we really, there was nothing else we could do. And our grants coordinator, bless her heart, with that particular organization, she was basically, filling out their invoices, helping them, sort through their, receipts. And it just would not have been able to sustain that for 3 years.
Right. And it's such a dilemma because many of those grassroots organizations have the best connections to the population that really needs to be reached and that you really need to reach.
Yes.
But they don't have the internal capacity or the tolerance for developing the internal capacity.
Yes. And that particular organization, when it came about, when we funded them, or when the grants committee, because there was a whole committee, of external partners put together to look and review the RFPs. Well, it was overlooked that they did not have their nonprofit or 501c3 status yet. However, as a partner, because we knew their reach, or we knew the work, we're familiar with the work in the community, we held their funding until they went through that process, and until they received that, which is, again, typically, definitely not something our auditors wanted. They're like, they don't qualify, redistribute the funds. But we wanted to partner with them. We wanted to have it. And so there were a lot of things that we just we couldn't have forecasted.
And there's a great irony in the juxtaposition of the formal system and this kind of informal system, because they do have the links that are so critical. Yeah. Great. Other questions, comments?
You mentioned it a little bit at the end about what you were thinking about, like ongoing capacity building or with these organizations you connected with. Have you thought at all, or how are you all thinking about, probably some of these were new organizations maybe to you all through the RFP, but like, what does continued relationship look like with some of these organizations, or any, like, did being in relationship in this way with organizations shift the way you're thinking about your work, you know, what you're doing now?
So yes to both. So one way that we are looking at, you know, maintaining relationships. So some of the orgs, we already had staff that were on their boards, if they had a board, or that were part of, you know, they're on our, you know, coalitions that we may run. So there was some of that, but those were, you know, very loose. Other than the board membership, you know, the coalitions, they may pop in and provide feedback. It wasn't as intimate of a relationship as we established with the funding process. And so going forward, what we are looking at establishing, which why we don't have one, I don't know, it's just one of those things you don't think about, I think, because we are on, so our Health Science Center, our public health program, has a community advisory board, but public health doesn't have a community advisory board, but we're on everybody else's board. And so we are looking at establishing an advisory board for public health, so that one, we're not scrambling whenever we need, you know, community feedback in different areas, but a more formal board that we would invite these partners as well as others to contribute to and be a part of, so that we, as we continue to look at the health assessment and health needs of Tarrant County as a whole, they're there. And so that is something I'm excited about, rolling that out and seeing what comes of that.
Yeah, until those relationships are built, we're not going to touch disparities. We're just not. I mean, I think we just don't get it without having those people at the table saying, you can't ask that in an RFP, not of the groups I know of. It's so interesting politically. There are organizations that fund grassroots groups who are connected to populations of color. And I send all my political money to them, not to the candidate, because the candidate doesn't know how to reach those populations. He runs ads with the Black person in them and says, oh, I reached the Black population. And these folks have been working in those communities forever, doing free lunches or whatever. And you give them some money, and you get much more bang for your buck. And I think you're looking for the equivalent in public health outreach. And I think the whole field is, and we're struggling. You see, we were doing work on community benefits with the Attorney General's office. And I remember one of the staff members from the Attorney General's office coming to our meeting, and we were translating because we'd recruited some of the, Hispanic population to be there. And she said to me afterwards, that took so long. I'm thinking, of course it does. I mean, you want to understand what you're saying, but you had a great example of people saying, yes, I hired a Hispanic population. None of us understand, a translator, none of us understand what they're saying. So, they may be able to communicate to the population, but they can't communicate with us. And I'm thinking, so build the capacity, and it's just so much more work than anybody's willing to do for that issue. And so it's really interesting when you stumble on it. Great. Well, this was a terrific talk. Any other final comments? I love getting into the intricacies of how to make this stuff work. And I think you did a beautiful job on that.
Thank you.
Final comments, Mark?
As a conclusion, well, in a way you scared me, we are about to to get a grant, not of this size, not with so many partners, but I see the complexity of this problem, and I think that we really need to prepare well to deal with this money and with all these partners. That's not just the fact that you are getting money doesn't give any warranty that you will accomplish the task, you know. So it will require a lot of preparations, and I look forward to get the materials from your project.
Yes, and then just like I said, reach out whenever if you think of questions after this. Definitely been a pleasure just to share. And like I said, there's so many things in that particular project, but it definitely has been, I think, an eye opener for our organization, just in us even doing the work, you know, being the great, because we were also a grantee. And so we were stumbling along the lines and along the way as well, and trying to reach various populations. And so, yeah, just excited to be part of the project. Thank you guys for taking the time to listen.